Welcome, welcome. So happy to have you on tonight. This is a series of sessions just to inform you about hormones and what's actually going on with your body, or what may be going on with your body in the near future. Whether you're going through perimenopause, whether you have symptoms, you don't have symptoms, whether you've gone through menopause, some of this will definitely help. So we hope to answer your questions tonight. So thank you so much for joining. And I will go ahead just give you an idea of what to expect tonight, because there's a few sessions we're having. So tonight is really about what to expect during perimenopause and menopause. I'm just letting people in as we join. Thank you all for joining. And also, we're going to talk about all the reasons why this hormonal shift is confusing. And there's so much confusion out there in terms of the symptoms people have, take hormones, not take hormones, why testing is different, why all the doctors say different things. We're going to talk about that. And then we're going to go through some Q&A. I also want to just introduce you to myself and Dr. Karen. For those that don't know either one of us, I'm a health and mindset coach. So I help people with anxiety, with burnout, health symptoms, and I help them to create peace of mind that they may have never had, to create energy that they once had when they were younger and vibrant. And we do this through all different types of techniques, but I really love to help people get healthier. And I have a private executive coaching program, a 3-month program that we work through to enhance so many things in just a short period of time. And I'd also like to introduce you to Dr. Karen Hartzenberg, who is a fantastic doctor for hundreds of reasons, which I could probably spend the whole hour talking about that. But without further ado, I'll let her introduce herself.
Thanks, Lindsay.
You're welcome.
So I'm a general practitioner working in Mauritius in private practice. My special interest or specialization is lifestyle medicine, which aligns well with what Lindsay does, in that I work mostly, or I like to work mostly, in preventive medicine, helping people prevent problems and promoting optimal health and wellness. And then on the side, I'm a group fitness instructor as well. So I've got a passion for healthy living, healthy lifestyle, and health promotion. And so I'm very grateful to Lindsay for inviting me to join on this call this evening. And hopefully we can give you a little bit more insight and information into hormones, hormone therapy, menopause, perimenopause, and what to expect.
Thank you. All right. Yes, I'm so glad that you joined. So thanks a lot. And if you've never seen her Zumba class, she's vibrant with energy. So it's quite amazing. Okay. So now let's just get into it. What do we expect during perimenopause and menopause? And it's a very crazy time because, we go through these monthly cycles as women. And then at some point, we hit menopause and perimenopause. So menopause is really at a place where you have no period for a year. Typically, it's an arbitrary definition. So they just had to give it something, and they said, okay, after a year of no period, because there'll be times for certain women that they'll have months without a period, and then all of a sudden they'll get a period. That doesn't classify as hitting menopause yet until they've had 12 months without a period. So the average age is 51. Some women, what's considered normal is anywhere between the age of 45 and 55. And that depends a lot on genetics and a few other factors. Then for perimenopause, the symptoms begin often 7 to 10 years before. Some references and resources will say 12 years. Some will say up, as low as 2 years before, but several years before. Some women don't get symptoms in perimenopause and menopause, and it's hitting around 15 to 20% don't really get the symptoms. But it doesn't mean that you don't need support, and we'll come to that in a little bit. Perimenopause often starts as early as 35 because that's when the progesterone starts declining. And I'll come to what the hormones mean and what they are and the characteristics. Dr. Karen, did you have anything to add, or shall I move on?
Well, a question that I get quite often from women is, when do they expect that they're going to hit the menopause? And it's quite a difficult question to answer, but the most reliable way of determining when you are likely to enter the menopause is looking at the maternal history. So like when your mom started menopause is probably the best predictor of when you are going to enter menopause. Obviously, there are other factors that contribute, like how many children you've had, fertility treatment, etc. But overall, you can kind of look and say, okay, if my mom had menopause early, like before the age of 45, I'm at a higher risk, in a way, of entering menopause early myself. And it's the same if she had menopause late, then it's more likely that I might have menopause later on. So that's just an interesting point.
Yeah, thank you. Okay, so I want to just talk about this life cycle hormones. This is from another doctor's reference. And as you can see, puberty hormones are kind of all over the place. And that's actually what happens. And I don't know that this graph is fully representative because the other hormones are doing this too. But a lot of women feel like they have this second puberty, and that's what it's called. So there's a lot of hormonal shifts in this period. And you could see that all of these, they're the sex hormones. These hormones go up for the reproductive years, and then they go back down. And a lot of these hormones decreased drastically over from the time that you're reproducing until the time you hit menopause.
And I think this is quite interesting because it shows that there's a period of time in most of our lives when our hormones are pretty stable. And so, during that reproductive time, most people have a very stable, kind of calm life because our hormones interact with everything that we do. Whereas if you look at adolescence, where it's like up and down, you can see why there's that sort of volatility during that time. And the same we can see during the perimenopause and menopause time as well.
It's intense. Okay, let's moving to the characteristics. So progesterone is known as the keep calm and carry on hormone, and it helps you literally stay calm and sleep well. So if it's low, which that's the first hormone to actually decrease, and that's the one that starts decreasing at around age 35, that causes sleep issues, anxiety, mood swings, shorter cycles, and spotting. But not everyone who has lower progesterone doesn't mean that you're going to have all of these symptoms. Sometimes it's just one of them. So it doesn't mean that if your cycles are still normal, that your progesterone isn't low or declining. Estrogen, sexy, sassy, feminine hormone. So when it's low, there will be all of these symptoms. I'm not going to read through all of them. Hot flashes, racing mind, weight gain, headaches, UTIs, mental fogginess. A lot of people talk about brain fog, lower libido, vaginal dryness, pain during intercourse, even hair loss can be a symptom of estrogen decline, even itchy ears, frozen shoulders, some other random things that I haven't mentioned here. Higher cholesterol. And the weight gain also happens because estrogen is insulin sensitizing. So it helps with blood sugar management. And the moment estrogen goes down, we don't have that protection anymore. And there's a lot of things that estrogen gives that really is protective. There's a book that I've been reading called Estrogen Matters, and it's really about the importance of estrogen throughout a woman's life, not just during the reproductive years. I also want to just talk about spikes. So as you saw in that last graph, at perimenopause, the late stages of perimenopause, so progesterone is like going down pretty steadily. Estrogen doesn't do the same thing. Estrogen goes up and down, up and down. So often women will have signs of estrogen dominance, another term for it, or they'll have spikes in estrogen and then they'll have the lows. So they may actually get both of these symptoms. And so the spikes are often signified by heavy periods, PMS symptoms, cramps. I have stuff covering the rest of this, but breast tenderness is one of the telltale signs of an estrogen spike. And I don't know, Dr. Karen, if you want to mention anything about these two key hormones.
Well, in my experience, like most of the time, women will come with two presentations, really. The one is a lot of the estrogen symptoms, where like the hot flushes and stuff. But another very common presentation that I see a lot is joint pains, like achiness and feeling sore. And you don't automatically associate that symptom with menopause, but it's one of the things that I've seen often is like people wake up in the morning and they're like, oh, I'm stiff, I'm sore. They think they've got arthritis or something. And then it's actually because of the drop in the hormones.
Yeah, and that's intense. Actually, I think a lot of women's symptoms, they don't necessarily attribute to drop in hormones because their cycles are normal. So they think, okay, it has nothing to do with that. But there's a huge relationship. Hormones do so much. And actually, for osteoporosis, estrogen is one of the main treatments for the prevention of osteoporosis. Okay.
Okay.
So I'm going to talk briefly about these because these issues don't hit as much during the perimenopause phase, but more hit during um, postmenopausal. Doesn't mean it's not important. Doesn't mean we don't need to know. But it's testosterone is kind of the confidence, muscle, and motivation hormone. So when it's low, libido is low. Often it can become low after years of taking birth control, but that's a story for another day. It can cause low libido, low energy, body hair loss, muscular weakness, flabbiness, and loss of sense of security. And men can have low testosterone as well. Also a story for another day. However, again, this is one of those hormones. So the progesterone is that keep calm, carry on, helps you sleep, helps with anxiety. That one steadily declines as of 35. Estrogen has its spikes and troughs, and testosterone generally, it also has spikes and troughs, but it's a little bit different in a presentation with each person. Often it will go high before it goes low in menopause. So the last years of perimenopause, women will get acne, oily skin, body hair growth, hair loss on their head. They'll get those spikes because it's actually a compensation for the lower hormones. Dr. Karen, I don't know if you want to mention anything else about testosterone.
I think it's just an interesting one because a lot of women do come and they complain about libido being low, and they attribute that to testosterone. And I've seen a lot of specialists prescribe testosterone treatment. One has to be quite careful because the side effects can be quite severe. And like you're saying, where if you've got a reactive spike and then you're adding more testosterone to the mix, you can end up with somebody not very happy with you. So it's one of those with women where we have to be very, very, very careful in prescribing it.
Yeah, and I forgot to mention when I did my introduction, I have this recent passion on hormones. So I've been taking a lot of hormones courses, and I've recently been taking something called the menopause method, which is normally training for doctors. But I really wanted to take it. I wanted to understand my own body and help others as well. Although I can't prescribe hormones, that's why I'm working with Dr. Karen. But one of the things is that it's really what I've learned in that menopause method. Generally, that low libido often is alleviated by fixing or improving estrogen levels. And the other thing is that method, generally they do progesterone and estrogen treatment way before they give testosterone and or DHEA. And that is something that once you get the other hormones in order, often testosterone will not be as big of an issue. But still, at this point, we'll talk about testing later, but testing testosterone would be good, especially after you've gotten the other hormones in order. Then DHEA, fountain of youth hormone, this steadily declines even earlier than 35, but this is not necessarily showing any obvious symptoms. It helps reduce inflammation, helps with insulin sensitivity, helps reduce belly fat, improves depression, anxiety. It does help. And for some women, they become quite low in DHEA as well. But this is later down the line after you've kind of taken care of the other hormones first. This is not the first port of call. And you also, again, have to be careful, as Dr. Karen was saying, because with DHEA, there can be, you'll get a lot of this is both testosterone and DHEA are androgens, and you'll get a lot of the high androgen symptoms if the dosage is not right. So we have to be careful with them. Okay. So I just wanted to show you something from the course that I've taken. So this is estrogen and progesterone. And these are kind of normal ranges for a menstruating woman. You may have the same. Progesterone is actually 100 times higher than estrogen, but in terms of ranges, you're looking at a normal range of estrogen, a normal range of progesterone. You can also have more estrogen, less progesterone. All of these would be someone who's menstruating, someone who's getting their period. Then at this point, treatment with estrogen, treatment with progesterone can often be very helpful if estrogen is declining, which it does in perimenopause, and progesterone is very lean. This is a good time to add progesterone. Also, if you're menstruating and you're not ovulating in these scenarios, and then obviously postmenopausal, not menstruating, not ovulating. Because sometimes women will get their periods, but they're not actually ovulating anymore. And the act of ovulation, they're releasing the egg, that corpus luteum, that's what actually produces the progesterone. But if there's no ovulation, you're not getting that progesterone at all, that keep calm and carry on hormone. Okay, so now we're going to go into a few reasons why this whole phase is confusing for a lot of people. And also at the end, we'll have time for some questions. So one, it's a fresh, hot topic. And why is it fresh? Well, only 100 years ago, women started living past the age of menopause. Until then, they were passing away before menopause. So it is very recent in history as as something to be studied. That's one, and there's a whole host of other reasons in terms of, like, you look at male versus female stereotypes and how women are treated in the medical system. And I'm not going to go into that. I don't know if Dr. Karen, you want to, but I'll just keep moving along. But it hasn't really been addressed until recently. Women are waking up and they want to know more and they want their symptoms to be treated. Women are so good at kind of handling problems and pain. I mean, we go through birth, we have a period every month, we have all sorts of things. And even my dad had told me, oh, women are just so much better at handling pain, like as if it's just a thing, which I love my dad, but I mean, that's just a normal thought. And I get it. And I agree with it. Women are used to handling pain, but it doesn't mean we need to continue to handle and to suffer if we don't need to. It's considered a normal part of aging, and women will get through it silently. And 80%, so it's actually 80 to 85% of women have menopause symptoms that do impact their quality of life. And the menopause method that I was trained in, they say 100% of women get to hormone levels that are too low, that will not protect you against bladder issues and bone loss and protect your arteries and cognitive decline. So even if you don't have symptoms, the studies are now showing, after 20 years of follow-up and everything like that, of multiple different trials, that the hormones are actually protective, and you need a certain level to have that protection. Once you hit menopause, we don't have that level anymore because our ovaries are not producing that level. So only the fat tissue in our body and our adrenal glands start producing those hormones, but they're tiny, tiny amounts relative to what we have seen in the reproductive years. And also economically, it's a hot topic because now we're seeing that the economy is losing millions of dollars because women are reporting menopause as the reason why they're not coming into work and things like that. So people are really waking up in that sense. Dr. Karen, do you have anything to add to this?
Well, what's interesting is, like, in the medical field, we've only really started recently doing research into this. When I was a student, for instance, I didn't have any training on menopause. And like you said, it was considered a normal kind of phase of life. And therefore, it didn't really require any kind of intervention or attention or treatment. And so now, it's only now that we're really looking into research around what are the treatment options, what are the real risks and benefits. And so there's a lot more attention being drawn in the research side, and that's only recent. So the data that we have, most of it is pretty old and not that helpful from my experience when I trained. So it's doctors who are switched on and who are interested who will actually have new knowledge and understanding of what's going on.
Yeah. And recently there's been more training programs and things that have popped up because people do not want to go through this phase unaware and facing issues that they don't need to face, and facing, I mean, at the end of the day, many people are focused on longevity, and not only longevity. My passion is health span, which is the quality of your years. And having higher quality of years often involves looking at menopause in a totally different light. Okay, so the next cause of confusion, the previous WHI study on risk, that the Women's Health Initiative, hundreds of thousands of people, maybe I don't know the exact number, I forgot, but there are so many flaws with that study, because what happened is in 2002, there was a press conference, there was a press release saying hormones cause cancer, hormones cause heart disease. And then every single doctor in the world, I mean, I've listened to podcasts, heard other doctors as well. They said it was like, that's a day they remember. It was like 9/11 for them, which they stopped prescribing hormones because then they realized it wasn't good. Since then, most of those WHI investigators they've debunked and rescinded most of their claims because they've republished and restudied and looked at the data in different ways and also kept studying the same people. And so, but there were also some flaws involved with that study. Most women, most people were not representative of the population. Most women were overweight with an average BMI of 28.5. And so that's already a risk factor for heart disease and certain cancers, including breast cancer. 70% of the participants were 10 years post-menopause. And that is very interesting because when you're looking at the protective benefits of hormones, what they've seen in the studies is actually the earlier you start, versus the later post-menopause that you start, you're actually getting protection. So when you wait over 10 years post-menopause, it actually doesn't offer the same protection. And on the contrary, there's a couple of risks associated, because if you wait, and I was planning to get to that later, but you're probably wondering, if you wait, for example, estrogen actually is a vasodilator. It kind of relaxes the blood vessels. It's great for blood vessels. But what happens is if the woman hasn't been on estrogen for a long time, and her estrogen, obviously she's not producing as much anymore, the arteries can build up plaques. And once you start taking estrogen again, those plaques kind of become loose, and that's what can cause clots. And so that's the theory of why they think that that's the case. But when a woman starts earlier, she doesn't have those same risks. So 70% of people being 10 years post-menopause is not representative of the population. And then that study specifically excluded people with menopausal symptoms. Only 13% had moderate or severe symptoms. And if you remember, I mentioned that the majority of women do have symptoms. So it's just not looking at the right population. Also, the WHI study only looked at one dose, which actually they look at now and they see that it was too high for older women. And I cannot see this because I have captions on. I need to remove the captions. I cannot see the rest of my slide because it's covering it. And let me try to do it from memory. So I think it's the second point is oral. So
the type of estrogen. That's the thing. The type of estrogen that they used was, number one, a synthetic type of estrogen, which is not the same as the estrogen that's found in your body. The dosage was significantly higher, and all of the people in the study got the oral dosage, which currently we know that treating with oral estrogen is probably not your first choice, because that has an impact on your liver metabolism. So, there were a couple of things relating to the actual medication they were using in the study that would have swung the results in the negative direction.
Yeah, no, that's such a good point. And now I moved my captions. I figured out how to do it. But yeah, that's the thing. Oral has much higher doses because it has to pass through the liver. So it's not the dosages that you would see in other formulations, especially transdermal, which is topical, which is what you apply on the skin. And yes, synthetic. And now there's a whole big talk about bioidentical, which is not synthetic. It's actually the hormones that are made in the body. And synthetic hormones are, like, for example, estrogen it's horse urine is what they're using as the synthetic version, whereas natural is the exact compound that the body makes. So our body is used to understanding and coping and managing that type of hormone. Okay, let me go to the next one. So debunking myths. We've talked about this on our breast cancer call, but at a high level, estrogen doesn't cause breast cancer. It actually decreases the risk when you look at the relative risk and when they look at the studies, and it decreases the risk from breast cancer and risk from death from all causes. There is controversy about estrogen receptor positive breast cancer, but they're even seeing with women with the BRCA gene that it still decreases the risk. And if you even had breast cancer and it's properly treated, that estrogen actually decreases the risk. So very flip, a big turn of events from what we had previously heard. And also, if you think about it in a different way, if it were the cause of breast cancer would likely decline after menopause, but it increases even though our estrogen decreases as well. So it's the opposite way. And dosage is important because excess can. And the majority of breast cancer patients have never taken estrogen. The majority of women who have never taken hormones have never had breast cancer. So there's this huge, I think, veil that we need to remove. And I just want to reiterate this so that we remove that veil. Women who are treated with hormones are at less risk for breast cancer, heart attack, stroke, bone loss, vaginal atrophy than women who aren't treated. And that's actually with synthetic, that. So now that when they've looked at the studies, and then bioidentical has even better outcomes. So hormone replacement therapy. Sorry, Dr. Karen, did you have anything you wanted to add?
Not particularly. The only thing is that there is always this question of if you've got a family history of breast cancer, if you've got a personal history of breast cancer, is hormone therapy an option for you? And you know, there is still a hesitation from the side of doctors because we don't always know the type of breast cancer that runs in families, and we don't always know the type of cancer that one might have had. So, and like Lindsay said, we've got to have a very careful dosage strategy to make sure that our safety, you know, that we're working in a safe way. So you will inevitably find, if you talk to a doctor, they will ask you, when you're considering hormone therapy, have you had breast cancer, or has someone in your family had breast cancer? And if you answer yes to that question, then you will be met with hesitation, because we are still a little bit scared about using it, because estrogen, we know that estrogen can have a stimulation effect on breast tissue. So it's just to understand that even though the studies are coming out showing that there's good safety data, on an individual level, we've still got to be cautious.
Yeah, that makes sense. And sometimes even with women who are being treated in chemo, they're still giving vaginal estrogen because they're not seeing a risk there, but there's all sorts of different ways, and it's a very individual, it should be individualized for each person. And also make sure you find a doctor who'll be willing to support you, because some women do report that, well, not only the women who are reporting, but the studies don't show that. So always need to take that precautionary approach, as Dr. Karen said. Okay, HRT. So it's the most effective treatment for managing menopause symptoms. That's what has been shown in the studies and also menopause societies across the globe. It's not generally recommended. So here we go. If you've had a history of stroke or deep vein thrombosis, breast cancer, estrogen receptor positive, or endometrial cancer. But again, there are exceptions for that. Just because of that history, it's a bit controversial, and severe liver disease. And Dr. Karen, is there anything else?
Well, I think, again, you know, it's always a question of, you've got to weigh up the potential benefit. And this goes for any medical treatment, for any medical, you know, condition. You have to weigh up the potential benefit of using a treatment versus the potential risk that you might be placing yourself at if you take the treatment. So, you know, you've got to look at that equation. And I mean, I've had patients who've had a previous history of a thrombosis, and they say to me, well, you know, either I'm going to kill myself or I'm going to kill my husband. So on that side of the equation, I'd rather have a thrombosis than feel the way I'm feeling. And then you say, okay, well, then it's really your choice according to that risk benefit kind of equation, you know. So we are in the business of keeping people alive in these circumstances. Yeah, that's how it goes.
That's a good point. Oh, geez. Yeah, no, and there's so many different scenarios that you really have to, it's really individual. And this is something okay, so conjugated equine estrogen is the horse urine, that's a synthetic, and this is actually a synthetic progesterone. This was what was the biggest study. It does not increase the risk of breast cancer development for those with a family history of breast cancer if you start the HRT within 10 years of the last menstrual period. So they're finding protective benefit the earlier you start. And this is when they did this study, they weren't really testing in perimenopause, but they're finding a lot of people are getting benefit from doing HRT in perimenopause. Okay. The next cause of confusion is there's so many other things, these other health factors that are, I don't think I have a slide on that one, that are causing confusion on what's actually a hormone issue. Because a lot of times, some of the same symptoms you'll get in progesterone and estrogen deficiency, there's some overlap with thyroid. And if thyroid is not kind of managed first, then the other hormones are going to be out of whack as well. And there are some doctors who would say you need to manage those hormones and thyroid will get into place, but thyroid does need to be managed. Sometimes hair loss is from a nutritional deficiency, for example. When our insulin is, we've got insulin resistance, then we may have belly fat or weight gain that is not necessarily because of an estrogen decline, high stress, those types of things. So there are so many other things that we need to take into consideration before you look at hormones or in tandem with hormones, because we really need, and I mentioned high stress. I didn't mention high stress, but stress is huge. I mean, what can cause anxiety and sleeplessness is not only a progesterone decline, and even estrogen can cause a racing mind at night, or you wake up with the hot flashes. But high stress is really something that needs to be addressed. And I have a personal passion for stress or managing stress, because I have had very high stress in my life. And it's really not about the stress itself, it's about the stress response and how we respond to stress. And if we can, it's like a muscle that you can enhance and build up resilience towards. It doesn't mean you don't change the external circumstances, but there's a lot of stuff internally that we can change so that we're not as reactive to stress, or don't think of things that keep us up at night and all those things. So all these things have to be to be managed either before or in tandem with hormones.
I think, from a practical clinical perspective, it's one of the more difficult situations to have, where, somebody will come to you and say, I'm tired, my concentration's not good, I'm not sleeping. Now and then I get a flush, but, that's probably because I've had a bad day. I'm irritable. And especially when their periods are normal, and that can happen, is that you can continue to have normal periods and it's not affected. So then we, as the clinicians, sit with the question of, okay, you've got to work through a list of possible causes and come to that conclusion that it could well be perimenopause that's starting. So it is one of those sort of diagnostic difficult situations, and to try and figure out that this is the case, because again, you don't want to expose somebody to unnecessary treatment or the incorrect treatment, because then their symptoms are not going to resolve. So it can be quite tricky.
Yeah. Okay, next is cause of confusion is bioindividuality, and so many things can affect each person differently. We've kind of covered this in the other health factors, the last point, but genetics, lifestyle, environment, other things. We need to make sure that we're detoxifying. I just threw this in there because especially if someone's genetically prone to detoxify slowly, they're likely prone to detoxify estrogen slowly. And an accumulation of excess estrogens can create DNA adducts, which can cause cancers. So if someone is prone to detoxify poorly, it's important that you are detoxifying your estrogens. How do you do that? Normal type of detoxification things, which sweating is great, cruciferous vegetables are great, broccoli sprouts, the sulforaphane in broccoli sprouts, it's like a superfood. Fasting is helpful for that. Sleeping well, it helps you detoxify at night. There's many other factors, and also avoiding the BPA and those plastics and things like that, and avoiding just heavy toxins and smoking. That is important. But every single person handles things differently, has different symptoms, has different way of accumulating their hormones, has different cycles, has so many different things. And there's no one person that if you go through perimenopause will have the exact same experience as another, because there's so many other factors involved. The response and absorption of hormones varies. For some, it's a game changer. They'll just take, like, even for me, I started having symptoms of perimenopause, and I started doing, all the supplement, the non-hormone things, because at the point before I had proper training, I was kind of against hormones, because it was, like similar to a medicine, and we should be able to just go through this naturally, was my approach. And so I took the chasteberry supplements and the maca and had the seed cycling and all of this. And at some point that helped, but then at some point it doesn't help anymore because the decline is just too much. Those things aren't going to actually make a move. And then, you've got people who would take chasteberry, which is just a nice supplement to help increase your own progesterone. But if you've got abnormal prolactin, it actually can make things worse. Black cohosh can affect the liver. So there's all these supplements that have other side effects, and they actually don't move the needle as much as just a hormone does. And so I started taking progesterone as a topical cream in Mauritius, and then also a bit of estrogen, a small amount. And it is a game changer. It's been a game changer for me. And once you will discuss with your doctor if that's something you want to do, it's been extremely helpful. But that doesn't happen with everyone. So we just need to know that there's that bio-individuality. I don't know, Dr. Karen, do you want to add anything?
Perfect. It's the truth. Everybody reacts differently. Everybody experiences this whole process differently. And it's kind of what makes it fun and exciting in a way, but also adds a little bit of extra challenge to getting things in balance and helping,
Yeah. Okay. So the last one, doctors, testing, and treatment views. So this, I'll have my own view based on what I see. And then obviously Dr. Karen will have her own. She's already mentioned some of this, but education and resources vary. And as she mentioned earlier, there was no training on this. And even now, I don't know that every program is requiring training. Even OBGYNs are mentioning that they got like 6 hours of training and that was it. So I think it is improving, but it's still not completely ubiquitous. And so it's not taught in most medical schools or programs. There was the WHI study confusion, which we mentioned earlier. The Menopause Society, it's North American Menopause Society, doesn't recommend testing. So now I'm not talking about the education. I'm talking about the view on testing. They don't recommend testing hormones because hormones fluctuate throughout the day and the month. So even if when a woman is cycling or in perimenopause, kind of semi-cycling, the hormones are going to be different throughout the month. And even progesterone has like a 90-minute cycle. So if you test in one moment and then you test an hour later, you're going to get a different number. So most societies and studies don't see that it's reliable, which is crazy because you're thinking, well, how can I take hormones if I don't know my hormone level? Doesn't apply to all hormones, but there is a lot of confusion about it. And then other training programs recommend, like the program I took, they do recommend to test post-menopausal, not perimenopause, because here they say perimenopause is a moving target. So you saw how earlier I was talking about how the estrogen goes up and down. It is not necessarily correlating with symptoms. It's not going to give you an accurate depiction. But postmenopausal, the reason why some programs recommend it is to make sure that you aren't too low, because some women don't get symptoms of deficiency and they actually don't have enough estrogen to protect their bones, their brain health, vaginal health, and for their arterial, like their heart health. And so we want to make sure that they still have enough, even if they're not getting symptoms. And then obviously you want to just test that it's not way too high, but normally any woman will get symptoms if it's way too high. That's at least what they have seen clinically. Bioindividuality of the person. Obviously the doctor has their own method of assessing and checking. And then there's also inconsistent data on superiority of the blood test versus urine test versus saliva. There's different takes on all of this. And then with all of that said, though, still annual medical testing is necessary. So not necessarily hormone testing, but medical testing is necessary prior to taking hormones or even continuing on hormones, because there are things that can change, things that can develop, there are risks. So you need to get clearance by a doctor, or in the US by a doctor or a nurse practitioner to get clearance to take hormones.
I think, yes, at this point, I do just want to mention that it's a medical treatment. So even though there's now a mindset around bioidentical hormone therapy being the same molecule as what's in your body, then people think that, it's like taking a vitamin, but it's not the case. So the same as, for instance, thyroid hormone is exactly the same molecule as what your thyroid produces. We still have to monitor that balance and make sure that everything is correct so that you don't run into problems of either under treatment, like Lindsay mentioned, where you're not achieving the benefits, or over treatment, where you might be exposing yourself to unnecessary risks. So it's essential that before we consider hormone therapy, that we have certain tests done, and that if you are on hormone therapy, that one needs to have that monitored, at a regular interval to make sure that everything is going well and that you're in a good balance.
Yeah. And the only thing I will say and to add on to this is sometimes I will recommend someone, most likely in Mauritius, it's very easy because I just recommend them to come to you or one of the OBGYNs that I've talked to before and is aligned. But in the US, it is very difficult for so many women to find someone who's going to be supportive. I just had a friend tell me today that she went and checked, and the doctor said, well, your cycles are regular. You don't need anything. Your hair loss, go to a dermatologist. Like, this is crazy because she's having other symptoms of sleeplessness and other things, and they're getting completely dismissed. So if you're in the US and you're watching this, just Google North American, or actually not even North American anymore. They've changed it to the Menopause Society. Google Menopause Society doctors. And the first link, at least that came up for me, was the North American Menopause Society website. And you can enter your zip code and it will give you practitioners that have been trained in the Menopause Society. And those are really good doctors because they do support through perimenopause, and they would help with hormones because not everyone is educated in this. So it's important to make sure you get someone who really understands this if you're in the US. If you're in Mauritius, you go to Dr. Karen. Okay. So before we go to Q&A, I just want to talk about what's next, because I imagine some of the questions will come up regarding this and we need more time to talk about it. But how do you know if you're a good candidate? Well, we talked a little bit about it today because there are tests that you need to do, just regular blood test and your normal gynae test. Hormones, pros and cons, the advantages of HRT, the risk of taking versus not taking. We touched a little bit, but we'll go in more detail. The best food and lifestyle support for healthy hormones, good nutrition, movement, sleep, connection, and peace of mind, basically stress reduction. Using bioidentical hormone therapy and how to access them in Mauritius, but also we'll talk a little bit about the US because I know people are calling from the US here. Supervision of treatment and testing. Not only the testing to get the clearance from your doctor to take hormones and to continue, but also hormone testing because some people want to get tested anyway, given what I've mentioned. So I've been so happy to share this with you because I feel like a lot of people are in the dark. I was totally in the dark about this period until recently. So I just wanted to check if anyone wants to ask a question. You could type it in the chat, or you can, let's see, raise your hand. I think that option will work. So I'll just wait a moment. And Dr. Karen, I don't know if you want to mention anything in the meantime.
So one of the questions in the chat is, how do you find out how to detox? I think, Lindsay, you can probably answer that one the best.
Okay. So firstly, not everyone detoxes slowly. I do genetic testing, like a saliva test that we send abroad, and we can understand if someone is prone to detoxifying slowly or they're good at detox. If they're slow at detox, then generally a lot of the recommendations involve certain types of foods that help with detox. Also avoiding exposure to certain things that are quite toxic. A lot of these, for example, air freshener is not something that we think of as highly toxic, but it's highly toxic, or certain cleaning chemicals. Not everyone will want to do everything, but at least okay, here are a few things I could do to help my body detoxify. Sauna and sweating is great. So that hopefully will help. If you've done, so I'm looking at who asked the question. So Debbie, the DNA test also is in the US. So let's chat if you want to go that route, because it's a really nice test to be able to understand your body's vulnerabilities. It gives you a blueprint of how your body works. And if you're a baby or 100, it's the same test. It just tells you what your body does well and what doesn't, and what are the things that you can do to kind of turn on the good genes and how to actually turn on your detoxification genes if they are slow. Annabelle asked, where do we find estrogen cream? So Annabelle, I think you're in Mauritius at the pharmacy, but again, as Dr. Karen said, it's important to get clearance by the doctor. There's things that we all need to, like small things, like you can't take estrogen without taking progesterone if you have a uterus. There's all sorts of things that it's important to know the right dosage from your doctor and all that. But it's at the pharmacy in Mauritius. They have bioidentical, which means not synthetic. They have progesterone cream and estrogen cream, but there are other forms that work for different people, just depending on your situation.
So can I just emphasize that point, is that I've had a couple of patients who have taken it upon themselves to get, hormone creams, because it is in Mauritius, it's available over the counter without prescription. And I know that you can also order it online in certain countries. But I've had probably 3 or 4 patients who have treated themselves with estrogen cream or gel, and one of them passed away from an endometrial cancer. So this is not, just like putting on a face cream or something. You really have to know that it's the right treatment for you. And like Lindsay said, if you have not had a hysterectomy, if you still have a uterus in place, you cannot use estrogen by itself. It can be very risky and quite dangerous. So rather, if you're interested in hormone therapy, please go the route of having proper care taken and having the treatment supervised.
Yeah, no, it's huge. Yeah. And wow, I didn't realize that people were doing that. And yeah, estrogen without progesterone leads to either endometrial hyperplasia or endometrial cancer. That's really crazy. So yeah, important to get that clearance by your doctor. And how do you know if your hormone levels are just right? What a great question. So 80 to 85% of the women will have symptoms. And with those, once you start, so the menopause method, the method that I've learned, basically you start on a low dose of progesterone and estrogen first. And a low dose. You wait a week to 1 to 2 weeks, usually about 10 days, and you see if your symptoms are alleviated. If they're alleviated, you actually go up a dose, or even if they're not alleviated, you go up. If you have symptoms of excess, you do not go up. So they give a chart basically to show you what the symptoms of deficiency symptoms are, what the symptoms of excess are. And when you have symptoms of deficiency, you keep increasing about every week to 2 weeks until you have symptoms of excess. Then you go back down, and that's kind of your optimal dose for now. Then if you're postmenopausal, they recommend doing a 24-hour urine test, just test that your levels are within range. If you're perimenopausal, they don't test. It's just about alleviating symptoms at this point, because you still have, your hormones aren't that low yet. But once they hit postmenopause, then they become really low. I don't know, Dr. Karen, you may have a different approach.
So in my practice, I get this question a lot, is can I test my hormones and check and see that they're fine? If a lady is having regular normal periods that have not changed from her normal cycle, and she's feeling fabulous, then we can infer that your hormones are in a good level and in a good balance. However, if there is a change in your periods, or there's a change in how you feel, and we think that there might be a hormonal reason for that, then typically there are 4 hormones that you check, and we can check it either on day 3 of the cycle or on day 21 of the cycle, which can give us quite a lot of information. So usually we check 2 hormones that come from the brain that are responsible for telling the ovaries to work. And then we test estrogen and progesterone. And typically what we see if somebody is entering the perimenopausal phase is that the hormones from the brain tend to increase. And then we can say, okay, hormones are probably not in a good balance. So from a practical perspective, we can test at specific times in the cycle, and we can see if the hormones look like they are in balance or not.
And you can even test if you're not cycling, you can still test, because those hormones Dr. Karen is talking about is FSH and LH, and those are going to be quite high at the time of menopause. They're going to keep kind of creeping up as you get through it. And then the reason why is because it's trying to tell the brain to produce more estrogen and progesterone, and there's not enough to produce anymore. And that's why it keeps creeping up. Okay, so Julia asked a really great question. Is the main point of therapy to manage the potentially uncomfortable symptoms linked to perimenopause and menopause? Would the therapy then become a long-term thing, or is there a point at which you can be fine without these hormones? So what I initially thought was, okay, it's just to manage symptoms. Now it is to manage symptoms because we shouldn't really have to suffer unnecessarily. And some people are really strong. They're like, I can get through this. Some people don't even have symptoms. The menopause method, the course that I've taken, and based on the studies that have been shown, they have the belief, and I have this belief too, that and Dr. Karen may have a slightly different view. So it's all about, as we said, bioindividuality. But I personally believe that every single woman who doesn't have a contraindication, like the ones that we mentioned earlier, would benefit from hormone therapy, not only from symptom alleviation, but because of the protective benefits that you get for bone health, for genital urinary symptoms, which is basically like vaginal atrophy, bladder, changing the bladder, the pelvic muscles, all of those things change over time. So you don't have to wear Depends. So bone health, vaginal health, heart health, it's very protective. I mean, the increase of heart disease goes up by 40 to 50% once a woman hits menopause, and that can be largely prevented by estrogen. And lastly, cognitive health, Alzheimer's, all these brain benefits. I mean, women report that they're losing their memory, brain fog, all of this. For life, I believe that a woman should be on hormones. And that's not, I was shocked the first time I heard these practitioners or experts that I follow say for life. Like, I thought it was just a temporary thing for life. So the dosage will obviously change. You don't need as high of a dose as you need when you're younger. We're supposed to have lower hormones, and you should never be taking hormones that will give you a period or anything like that. There are some programs that do that. That's way too much. But that's my personal belief, as long as you don't have any medical contraindications and you're not currently being treated for breast cancer and things like that.
So I'll give the medical side of the equation just for another view, is that internationally, all the menopause societies and associations will recommend 2 reasons to treat a lady with hormone therapy. The first one is menopause symptoms, because they obviously can be debilitating and quite severe. So hormone therapy is registered for the use to treat menopause symptoms by itself. The second reason, from a medical perspective, that we would use hormone therapy would be to either prevent or treat osteopenia or osteoporosis. So that is loss of bone density. And I think this is quite an important point, is that a lot of women don't think about their bones because it's not something you see or you feel. But hormone therapy is one of the main treatments that we have for protecting bone density. And so for anybody who's at risk of low bone density, hormone therapy is quite a strong recommendation, or we think about it quite a lot. So those are our 2 medical indications for using hormone therapy. The question of when to stop is one that is extremely controversial. In a lot of the guidelines, they will say not to continue hormone therapy after the age of 65. That's because we actually don't have that much long-term data for women who are older than that, who've been treated long-term with hormone therapy. So the general recommendation is when you're 65, we would say, try and wean off the hormone therapy. But having said that, at my previous practice in Cape Town, I had a most delightful patient. I met her when I joined the practice, and at that time she was 99 years old. And she was fit. She was like doing ballet every day, practicing yoga, walking, independent, very healthy and well. And she said to me, "Doctor, you can do anything, but you don't stop my hormones." So I said, okay, well, that's what the guidelines said, 65, you've been going for 30 years beyond that. And I left the practice when she was 103 years old, and she was still in perfect health. So, we have anecdotal examples where people really benefit from hormone therapy off label, where we're using the hormones without following the clinical guidelines. So I think we still have to wait for the guidelines to change, but I suspect that we are going to see changes in the next 10 to 15 years when we've got more data to work with.
Right. Thank you. That was super helpful. I feel like you are the yin to my yang, Dr. Karen. So thank you so much. And it was so wonderful to have all of you on. If we're going to be talking more, so if you have more questions, you could send them my way, send them on an email if you want. But also, there's more discussion to be had. I'll send out the replay. And if you know anyone that you think would benefit from seeing the replay or signing up for more of the calls, please share it, like with one person, just for, every woman. It's helpful for them to know what's going on, what's happening. So thank you all so much. Dr. Karen, thank you so much. And sending you lots of love, lots of health, and good vibes. Thank you so much. Talk to you soon.
Okay, bye.